Hey, good morning and welcome to HFRC's webinar for this month on diabetes and discussing some of the latest trends in diabetes management, prevention, and how do we combat this condition? So my name, for those who don't know, I presume people do, there's a few names on there that I recognise, but my name is David and I'm an exercise physiologist here at HFRC. Working kind of in this diabetes, weight loss, metabolic health space. So let's work through. So just to give you a bit of a background, we've all 2020 was the year of the pandemic, COVID-19, but really the big pandemic sweeping the world is diabetes. I mean, if we look at some of the stats in Australia, there's almost 2 million people with or at risk of type 2 diabetes. The cost to the country is enormous, and it's always hard to get these numbers because they're changing all the time, but, costing us $14 billion a year. And just in WA, a report that was done last year, well, actually not last year, the year before, last year disappeared. The year before estimated that the cost in WA alone was $1 billion for the management and treatment of diabetes, typically type 2 diabetes, and predominantly today is about type 2 diabetes, but some of the things apply to type 1 diabetics just as much. And it's not just the costs, not just the cost to the country, but the cost to people who have type 2 diabetes. The medications are expensive, and then if the condition is not managed well, people end up with lots of chronic conditions, ending up in hospital with kidney disease, with eye damage, loss of sight. Diabetes is one of the biggest causes of blindness in Australia, and amputations sadly is one of the problems. And partly that's because we've been treating the symptoms for a long time and not necessarily treating the root causes of diabetes. I want to try and get into that a little bit today so people have a bit of an understanding about that. So what is, my little cursor here. So what is diabetes? Essentially, diabetes is defined as a problem with too much glucose floating around in the blood. So, we hear about blood glucose all the time, high blood sugar levels. Our bodies can store about 4 grams of glucose in the blood. Now, to put that in context, that's about a teaspoonful of sugar. So then we can store, about 400 grams in our muscles, or we can store about 400 grams in our liver, and we can store about a day's supply, about 1,200 grams, I guess, in or 1,200 calories in our muscles. So we haven't got a very good storage capacity for storing glucose. And it's really important from a health perspective that we keep that blood glucose levels consistent within the blood, within a narrow band. Otherwise, the body doesn't like it. So that's essentially where the what diabetes is and how it's diagnosed. Oh, I'm going to get onto how it's diagnosed in a minute. So what are some of the signs and symptoms? I guess what are the early ones? Weight gain, particularly around the middle. Fatigue. Weight loss can be an issue, but it's typically early on it's weight gain. Excessive thirst, because we're trying to get rid of glucose out of the system. We go to the toilet a lot to try and excrete some glucose, so we go to the toilet more. We can start to get irritable and fatigued. They're quite common with diabetes in the early stages. Like I said, our vision can start to blur, and blindness is one of the significant causes. Where we get wounds that don't heal very well because our blood flow to the periphery is not very good. Skin infections, and also some darkening patches on the skin. So if you've got sort of dark patches under your arms, around your neck, or little skin tags. If you're someone who's got quite a lot of little skin tags, that's a sign of diabetes. You can get breath changes where you start to get that acetone fruity taste or fruity smell, like you've been out drinking wine the night before, and some tingling and numbness in the feet. So there's some of the signs and symptoms of diabetes. Now, also, it's not just diabetes, and I mentioned before about pre-diabetes, or what is pre-diabetes, and I think pre-diabetes is a bit of a misnomer in a way. It's a bit like saying someone in their first trimester is only a little bit pregnant. People are on the continuum of diabetes. So pre-diabetes, if you define it in the medical term, is where the blood sugar levels are a bit high, but they're not quite high enough to be categorized as diabetes. In my view, coming from a preventive kind of space, this is where we really need to tackle the issues. The earlier we can identify that people are at risk of diabetes, then the sooner we can make some lifestyle changes that prevent a lot of those complications and prevent the need for medical treatment. So like I said, pre-diabetes, where the blood sugar levels are a little bit high, that can still increase our risk for other things, heart disease and other health problems. So what are some of the early warning signs? A bit similar to what I went through before: urination, feeling like you need to go to the toilet more, increased thirst, fatigue and tiredness, putting weight on around the middle, particularly, well, no, not just men, but particularly we see men who aren't that overweight, but they've got that real little beer gut, that visceral fat, and that's a really good indicator of potential of pre-diabetes. So someone's heading towards that. How is diabetes diagnosed? Well, literally, it's a blood sugar reading. So, you know, when you get a fasting blood sugar level above 5.4 and a random blood sugar level, so random would be, you know, when you haven't fasted, above 6.9 millimoles per litre, and a HbA1c. So HbA1c is hemoglobin A1c, and for someone who's diabetic, that's a level above 6.5%. So let me explain what a HbA1c means. HbA1c is a measure of kind of the average blood sugar over the last 3 months. So when there's excess glucose in the blood, or not even excess, when there's glucose in the blood, some of that will stick to the hemoglobin. And the higher the blood sugar levels, the more it's going to stick to the hemoglobin. And so the HbA1c is a measure of what's the glycated hemoglobin. So what's the hemoglobin with glucose stuck to it. And if that's high, that's an indication that our blood sugar levels are high. Now, I was listening to a podcast just the other day by a insulin and diabetes expert, and he's saying not necessarily is HbA1c a great measure, because different people have different amounts of time that their hemoglobin lives for. Everything's got a half-life, and if someone's naturally got a half-life where their hemoglobin survive for longer before they start to break down, they might have higher HbA1c than someone whose hemoglobin turns over more quickly. So it's a very common measure, but it's not necessarily the best measure. And even fasting glucose and HbA1c, by the time they start to go up, someone's already, you know, progressed through their diabetes journey significantly. And I want to touch on that now. What's the diabetes journey that people go through? And this is again from that researcher I just mentioned. His name's Ben Bickman. And this shows really the time course for diabetes, looking at two things. It's looking at our glucose levels, and that's how we typically diagnose diabetes. But it's also looking at insulin. So I need to just go back a step and go, okay, what's insulin? Insulin is the hormone that the pancreas releases to manage our blood glucose levels. It's our energy management hormone, if you like. So it tells the body to store energy away, or when it's low, other hormones tell the body to release energy because we need it. So you can see here in the early days, if I can just get my cursor on here. In the early days, somebody's blood glucose levels might be quite normal, maybe going up just a little bit. But what's happening as they become insulin resistant, or their body's not responding to the effects of insulin, or their pancreas is having to work too hard, the insulin has to start going up. So the pancreas starts pumping out more and more insulin to keep our blood sugar levels normal. So somebody who is pre-diabetic might have relatively normal blood glucose levels, only a little bit high, but you can see that their insulin levels could be very, very high. And eventually their pancreas goes, this is all too hard. Can't produce as much anymore. Or the tissues become even more resistant. And so the amount of insulin being pumped out isn't enough to keep blood glucose levels under control. And this is when blood glucose levels start to go up. Let me just show you the next picture, which is a little bit more detailed examination of that. So if we look at fasting blood glucose levels, this was similar to the one in the last graph, so going up gradually. Postprandial glucose levels just means after you've eaten a meal, so kind of ignore that one for the moment. But if you have a look here at insulin secretion, the yellow one, you can see again that starts to go up, and that's the period of pre-diabetes. So insulin is high or starting to creep up during pre-diabetes before blood glucose does. Beta cell function is the function of the pancreas, the cells within the pancreas that release insulin. So you can see their function start to go down over time when they're kind of taxed a lot. You can see that insulin resistance keeps going up. But the two I really want you to focus on is this blood glucose and the insulin. And you can see that someone's pre-diabetic, even when their blood glucose level is normal, but their insulin's starting to creep up. And you can start to get some complications well before type 2 diabetes is officially diagnosed. And that's an issue for people. And I think it's something that's coming in more and more, is now more people, the medical profession, starting to go, well, okay, we need to get this early, not wait until out here when somebody's already got complications before we diagnose it. Now, I should have said right at the start, if you've got any questions, maybe just write them down or stick them in the chat box and we'll come back to them at the end. And I can answer any questions. I'm happy to spend quite a bit of time answering any questions as long as we need, because this is probably not going to go for the whole hour. I can't talk for that long. So here's the theory, or one of the theories about diabetes that's kind of coming more to the fore, I guess. And the theory or the belief is it's not just the high blood sugar levels that are causing the problems. In fact, there are some researchers that think, well, it's not the high blood glucose that's the real culprit in doing a lot of the damage. It's the high insulin levels. Now, I don't expect you to be able to necessarily read all this study, but here was a really good article going, well, it's not necessarily the blood glucose that's the problem. It's the high insulin levels that's the problem. Now, let me talk a little bit about what insulin does to give you a context for why this is so important. So I said before that insulin's our energy storage hormone. So it tells the body to any energy that comes into the body in food, it tells the body to store that away. It'll store it away as fat, and it'll store it away as glucose, which stores in the blood as blood glucose, in the liver as glycogen, and in the muscles as glycogen. So glycogen's really just blood glucose or stuck glucose levels, or not blood glucose, glucose combined to form glycogen. Now, insulin controls that process. And because it's our energy storage hormone, think polar bear, when we eat some food, we use up the energy that we need from that food at that point in time, but any excess we're going to store away for later. So we'll store away what we can in the blood, in the liver, in the muscles, but once those storage tanks are full, and they're not very big, like I said, 4 grams in the blood, about 400 in the liver and muscles, and about a day supply in the muscles. So the capacity to store glycogen is not very high. So then the insulin tells the liver to convert that extra sugar into fat to store away, because our capacity to store fat is pretty well unlimited. The other thing that insulin does is it will tell us not to burn up energy, because we're trying to store it away. So nature's pretty clever. We're not going to be trying to burn energy and store energy at the same time. So insulin will make us tired. It'll, if you've noticed that sleepy feeling after a meal, that's insulin doing its job. It'll stop us from burning fat. So it effectively stops the body from breaking down fat to release out into the system to use for energy. So if you've got high insulin levels and you're trying to lose body fat, that's a pretty difficult task, because insulin's basically telling the body, don't release any of that body fat to be used. What else does it do? It tells the kidneys to hold on to sodium, which is one of the theories behind why people with diabetes have high blood pressure, or one of the theories why we've got so much high blood pressure is because insulin is telling the kidneys to hold on to sodium salt. And with sodium in the system, higher levels of sodium comes more water, increases blood pressure. So insulin's implicated in a whole lot of things, and this is where the research is kind of tending to go. So it's not just, if I go back one, I guess the key point I want people to get out of this is thinking that it's not just the blood glucose that's the issue. That could be quite normal. In fact, I've had a number of clients who come in whose blood glucose levels are normal, and then when we get an insulin test done, their insulin levels are very high. What does that mean? Hold on to sodium, can't lose weight, tired all the time, putting weight on around the middle. Insulin will tell the body to store body fat, particularly that visceral body fat. So it's not just the blood glucose that's the issue. So insulin is the key kind of driving force, the root cause of a lot of this. So let me just change tack a little bit. What's a typical management of diabetes been over the time period? Now you can see I've got tablets on there, because the typical management of diabetes has been using drugs to manage our blood sugar levels. So the focus has been, it's all about the blood glucose levels. We've just got to keep that under control. And so drugs have been designed to do that. Now, diet has been a part, and I want to just, before I go on and talk about some of the drugs, I want to just touch on what is the dietary advice, what has been the dietary advice for people with diabetes over the last 20 to 30 years. I went to the Australian Diabetes Association website. Their standard advice has been generally to follow the Australian Dietary Guidelines. And so I went to the Australian Dietary Guidelines, and there's a number of them, but this was the key one that tells people what to eat. And some of these, I'll agree with some, and some of them I'll go, well, I'm not too sure that's quite right for diabetics. Now, this assumes that it's a one size fits all, and there is definitely, having worked in this space for a number of years, decades, it's definitely not a one size fits all. But let's look at these dietary guidelines. Eat a wide variety of nutritious foods from these 5 groups. Plenty of vegetables of different types and colors. No problem with that. I'm quite happy. I think, one of the issues is people don't eat enough vegetables. Legumes and beans are interesting because they're high in carbohydrate, and I'll explain in a little while why for some people that could be an issue. Listen, fruit, we should be eating fruit, but if I go back 10 to 15 years when I was training, and I could easily eat 6 or 7 pieces of fruit in a day, and I know people come in and think they're doing the right thing by eating lots of fruit, but there's a lot of sugar in fruit, and if we think that blood glucose is the issue, we don't want to be eating things that are very high in glucose. The next one's the one I really want to focus in on, grains and cereals, mostly the whole grains, well, I agree with that, but bread, cereals, rice, pasta, noodles, etc. are very high in carbohydrate, and carbohydrate breaks down into glucose. So hold that thought, because we'll come back to that. It says lean meat, poultry, fish, eggs, nuts and seeds. This has been a debate that's been going on, and I could run a whole workshop on just the nutrition world and how nutrition science is good, bad or otherwise. But the whole concept of lean meats is based on this fear that fat, particularly saturated fat, causes heart disease and causes cholesterol to go up. Like I said, we could run another whole session on that. Maybe I will sometime. But the evidence has been shown over and over again that fat does not cause cholesterol to go up. Fat does not, saturated fat does not implicate in higher risk of death or anything else. The studies that have shown that have been associational, not very good studies. And then looking at milk, yogurt, cheese, and or their alternatives. And again, it's this mostly reduced fat, which means it's typically going to be higher in sugar. So I would go forget the last little bit, but milk, yogurt, cheese, etc. Unless you're lactose intolerant, then dairy is not an issue for most people. What does that look like in a picture? Most people will have seen this. Let's eat. A lot of our energy coming from grains and cereals, and again breaking down into blood glucose. Lots of vegetables. Most of those, yes, vegetables are no problem because they're relatively low in sugar, but some of them are higher in carbohydrate. Fruit in moderation, and I think the old 5 and 2 is a good guide. Dairy products, not reduced fat ones, and I suspect this protein source, meat, eggs, fish, etc., seafood, should be higher than that for a lot of diabetics, and we'll get on to that in the next little bit. So that's been this typical dietary advice. Follow the Australian Dietary Guidelines, and we'll use drugs to manage your blood sugar levels because your blood sugars aren't where they should be. Let me just go back and say, some people can eat this way, and if you're fit and healthy, eating this way is not a problem. The Australian Dietary Guidelines are written for healthy people, not people with health conditions. Someone with diabetes has got a condition where they're not processing and utilising the carbohydrates and the glucose in their system very well. So these guidelines really aren't written for diabetics, although the Diabetes Association refers people to these, which I think is a mistake. I want to touch on some of the medications for diabetes, not so you're a full bottle of pharmacy, but so you get an idea of what these drugs are trying to achieve. So the bolded name is the name that's kind of the generic name, and then it's got some of the brand names which you might recognize if you're taking diabetes medications. So metformin, Diabex, what does it do? It tries to tell the liver to stop producing as much glucose, and it slows glucose release from the gut. So it's trying to reduce the amount of glucose getting into the blood, and it's going to improve insulin sensitivity. For most people, it's quite effective. Some people do have some common side effects with that. Sulfonylureas, common brand diamicron is the one that probably heard. What does it do? It tells the insulin to increase the amount of insulin to get our blood sugar levels down. What's the risk with that? Well, I mentioned before some of the side effects of having high insulin, and we're telling the pancreas to produce more. Blood sugar levels can go down. Anytime we tell the pancreas to release more insulin, weight gain's a risk. So if people are trying to lose weight and they're taking diabetes medications, it's very, very difficult. Yeah. DPP-4 inhibitors, Januvia is one that you may have heard here in Australia. What does it do? It blocks an enzyme, DPP-4 enzyme. So it tells the pancreas to release more insulin into the system, and it reduces the amount of glucose getting produced by the liver. So again, it puts us into energy storage mode. What are some of the side effects there, you can see some respiratory tract infections, cold infections, musculoskeletal pain. Relatively, whoop, sorry, hit the wrong button there. SGLT2 inhibitors, been seeing a bit more of these. What do? They basically, they tell the kidneys to stop reabsorbing glucose. So the kidneys are kind of our filters, and they filter out glucose to keep it in the body because it's an energy source. So they basically tell the kidneys to stop doing that. So we urinate out more blood glucose. So it's kind of going against what, that was one of the ways of testing in the early days, is to somebody was diabetic, was to look at measure the amount of glucose in their urine. What are the risks with that? Urinary tract infections, particularly in older people and particularly in women, dehydration, constipation, and because we're trying to get rid of more glucose, we go to the toilet more often. A couple of others here. Won't even try and pronounce. Thiazolidinones, yeah. Common brands. Oh, turn that off. Common brands. Avandia improves the insulin sensitivity of the cells, and it decreases the amount of glucose coming from the liver getting into the blood. What is the risk? Again, we increase weight gain because we're storing energy away. Our glucoside inhibitors slow the digestion of carbohydrates. So what these are trying to do is slow the release of carbohydrates being broken down from food and then glucose levels going up. So basically it's messing with our digestive process, can cause some diarrhea, some bloating, some wind. GLP-1 agonists are kind of new ones. So they block glucose release from the liver. So again, trying to keep our blood glucose levels down. They slow glucose release from the gut. They stimulate the release of insulin. So they can cause our insulin levels to go up, and they increase the feeling of fullness. So these are quite common and quite popular at the moment, but you can see there's some common side effects some people have. Again, increasing the amount of insulin is going to cause some of those problems with hyperinsulinemia. And then the last one, and the one that people want to really try and avoid going to, is actually artificial insulin being injected into the body, so that basically replaces the role of the pancreas and producing insulin. What does insulin do? It's our energy storage hormone. So we're going to put on weight. We're going to, yes, our blood sugar levels might go down, provided we're not too insulin resistant. The tissues aren't too insulin resistant, but we're going to store body fat away. We're not going to be able to lose weight. We're going to get tired. We're going to put on visceral fat. So there's, with all medications, there's side effects, and you can see that the predominant role of what they're trying to do is they're trying to keep our blood sugar levels down, and they do that predominantly by increasing insulin levels or reducing the absorption of glucose by the body. So here's an analogy of how the medication system kind of works. If you think of a car with a brake and an accelerator, got a clutch here as well because it's a manual, but most people haven't got manual cars anymore. But it's a bit like, eat the Australian Dietary Guidelines, or the standard food that people who are healthy can eat, with lots of grains and cereals and lots of fruit, which is putting lots of carbohydrates into the system, which is going to cause our blood glucose levels to go up. At the same time, let's give you drugs to try and get your blood glucose levels down. So it's a bit like having your foot on the accelerator and your foot on the brake and wondering why your car's having problems. That's how we've been treating diabetes for the last 30 or 40 years. Kind of doesn't make sense, and more there's pressure on to look at the way we treat diabetes, particularly with all those medications, when we're just eating in a way that stimulates the need for those medications. So what are the dietary strategies? What are the proven strategies to reverse diabetes? Now, for a long time, and I still hear this, people are told that diabetes is a lifelong progressive condition Once you've got it, it's just about managing the symptoms. And if you look back at what we've done for the last 30 or 40 years, you know, all the evidence would show that, because all we've done is manage the symptoms. We haven't actually tried to get to the root cause of the problem. So here are in the last 5 to 10 years, it's been shown that diabetes can be reversed. So it's not a lifelong condition that people have to live with. We can actually make changes and get people off medications. I've achieved that with some of my clients here in the clinic. What are the 3 proven dietary strategies to reverse diabetes? You'll see the first one I've got on there is bariatric surgery. And you're thinking, well, that's not a dietary strategy. It really is, because what bariatric surgery does, it's a short-term starvation mode model that doesn't let you eat anywhere near as much food. It's like going on a major low calorie diet. And it buys you time. If you talk to some of the bariatric surgeons who are more enlightened, they admit that the surgery just buys people time to change their lifestyle. Yes, people usually get a rapid weight loss because they're not eating much at all. They just physically can't. 1, because the capacity of their stomach. 2, because they feel pretty bad a lot of the time. But if people don't change their lifestyle, the success rate on long-term for bariatric surgery is probably about 30%. Those who change their lifestyle are the ones who will maintain it. So it is a dietary strategy, a very low-calorie diet. So it's very restrictive. And that's certainly been shown to do that. Michael Mosley's Fast 800, go on an 800-calorie diet for a number of weeks, and you can reverse your diabetes. The downside with that is it's possible to do, but people are often very hungry, and it's not something people can live with for a long extended period of time, because hunger just takes over. And also the other risk is that they start to lose muscle mass if they're not eating enough energy, and they're hungry all the time. They will start to, they won't get the protein requirements that they need to maintain muscle mass. And the third one is a low carb eating approach. It's been shown to be very effective. Of all the dietary lifestyle programs out there, low carbohydrate has been studied more than any others. It's very effective, but it does take support. It's, for some people they can just do it and go, but my experience is that people need some help along the way to work out what exactly works for them and what does low carb mean for them. So some people, low carb might be very, very restrictive to get the results, and others don't need to be as restrictive. Here are some of the programs just to give you a sense of, where this is at in the world. The American Diabetes Association in 2018 updated its standards of medical care to include low carb as a viable option, and I'll show you a slide in a minute about that, as has Australia, but a bit later. Diabetes UK is strong, and the UK is probably ahead of Australia in using dietary approaches to help combat diabetes. There was a review done in here in WA in 2019, looking at the approaches that were effective for diabetes remission. It came up with, the parliamentary review came up that low carb diet was a viable option. Sadly, the health department didn't want to support that. Bit of politics and entrenched positions, I think, in that one. But anyway, the parliament came up with that. Virta is a US company that has been advocating a low carb dietary approach, and they've got up to 2-year results showing significant success in reversing and sustaining the reversal of diabetes. Dr. James Mookie, who is 2020 Australian of the Year, has been a very vocal advocate and has been beating the drum about the Australian Dietary Guidelines have been contributing to the epidemic of diabetes in Australia. He's a ophthalmologist, so an eye surgeon, and got tired of you know, having to do surgery on people's eyes because diabetes was killing their eyesight. And Diversa Health, I put that on there. Diversa Health is a online, in Australia, an online low carb approach for reversing diabetes. Conflict of interest alert here. I'm their exercise advisor and one on their sort of advisory panel for the Diversa Health. They were operating out of Melbourne as the low carb GP clinic for a number of years, and they've just rebranded as Diversa Health. And clearly I work in this space, so I help people with diabetes and weight issues here in the clinic at HFRC. Just to give you an idea, this is from the American Diabetes Association, just to show what their website shows. You know, reducing overall carbohydrate intake has been demonstrated to have the most evidence for improving glycemia, so improving blood glucose levels, and is probably the most effective for individuals with type 2 diabetes. And if there's any type 1 diabetics, I can talk to them as well, because this has been shown to be effective with type 1s as well, but there's some other issues need to be aware of. What does that look like in space? And we're going to go into a bit more detail, but you know, non-starchy vegetables, minimizing added sugars and refined grains, choosing whole foods over processed foods. I don't think anyone could argue about that kind of recommendation. I just want to show you a graph of what we're trying to achieve. So this is a graph of blood glucose levels. It's very messy and complicated, but if you look at that black line, that's kind of the average blood glucose being monitored on a 24-hour monitor. And the green band that you can see there, so the green band between here and here, is where we want blood sugar levels to be. The red line is kind of the optimal, where we want it to be for somebody. This is somebody who is following the American Diabetes Association standard diet. So like that plate for Australia that I showed you, lots of grains and cereals, lean meat, and, you know, not too, you know, and lots of fruit. And also taking 13 units of bolus, so taking insulin injections with their meals to manage their blood glucose levels, and also taking a basal insulin injection. And they're eating about 225 grams of carbohydrates a day. So you can see their blood glucose levels is kind of all over the place, depending on what they've eaten and when they've injected their insulin. Remember, our aim is to keep our blood glucose levels in that green range. But then show you, here's the same profile of somebody who's been eating a low carbohydrate diet, taking no insulin injections with meals, and only 3 units of insulin as a basal level. So the other first example, someone was eating 225 grams of carbohydrates a day. This example, someone's eating 50 grams a day, and you can see they're in that green band and at the low end of that green band, which is not a bad thing. You know, our blood glucose levels, we need to have enough that everything functions well, but we don't want them too high, and we certainly don't want insulin too high. Now, this didn't measure insulin, but it shows you, but it was talking about how much insulin was being injected into the system to maintain that. I thought I'd just show you a graph comparing TCR, which is therapeutic carbohydrate restriction, so low carb diet, compared with one of those drugs. So this was the SGLT2 inhibitor, which tells the kidneys to excrete more glucose. So we're basically weaning glucose out when we go to the toilet. So what does it do? The low carb diet reduces the amount of glucose going into the system in the first place. The SGLT2 inhibitor says eat what you like, but increase the amount of glucose that we're sending out to the toilet. What does it do to our average hemoglobin A1C? Well, low carbohydrate reduces a lot, as does the SGLT2 inhibitor, but not as much. Our insulin levels go way, way down on a low carbohydrate diet. Now, not straight away, but eventually over time, our blood, and for some people very quickly, but they'll go down significantly. They'll go down a little bit with that drug. Weight loss will be greater with a low carb diet for most people than the SGLT2 inhibitor. Blood pressure typically goes down with a low carb diet because of what I talked about with high insulin and sodium. LDL cholesterol is an interesting one. And again, we could run a whole session on cholesterol because there's a whole lot of debate now as to whether LDL cholesterol is even a significant risk factor. But it can go down. And for some people, particularly leaner people, a low carb diet, their LDL cholesterol can go up. That's because they're using fat as a fuel, and LDL is just the way we, move fat around in the body. It can go up or down with the SGLT2 inhibitor. HDL, the supposedly good cholesterol, goes up with both. Our triglycerides, which again are fats stored in the blood, go way down with less carbohydrate, still go down with the SGLT2 inhibitor. Ketones, which are a byproduct of burning fat for fuel, goes up on a low carb diet and can do on SGLT2 inhibitors. And there are some side effects. So keto flu is a short-term process when the body's adapting to not having as much glucose in there, to adapting to a low carb diet, and starts burning fat. Some people get constipated, usually if they're not eating enough vegetables. And some people can get a little bit lightheaded, particularly if they're taking blood pressure medication, because the sodium levels get a little bit out of whack when people first go on a low carb diet. And you can see some of those risk factors. Urinary tract infections, because we're weaning out more glucose, the low blood pressure, and this was interesting, increased risk of amputation, which is not something anyone would want to have to deal with, I don't think. So, I mean, no surprise, you can see where the latest trend is going, and where my bias, I guess, is why don't we just stop putting more glucose into the system and carbohydrates into the system, and then dealing with it with drugs when we can deal with it from a dietary point of view, and stop taxing the system, our physiological system. Now, the talk was about, latest trends and new things, but I just want to highlight for people, this isn't necessarily all that new. So here's a copy of a textbook. So this was from 1923, Principles and Practices of Medicine, by William Osler in 1923. Let me just show you, and again, I don't expect you to be able to see all the detail on this, but here's a couple of pages from that textbook. Excuse me, put my glasses on, but there's a bit in here. It is important not to overtax the patient's powers of using carbohydrates by giving more than he can utilize. So the other thing it says is each patient presents his own problem and must be studied individually. So it's not a one size fits all. We need to study people, and we need to work out what's the amount of carbohydrate that people can handle. So the object of treatment is to increase the carbohydrate tolerance, but we need to go back. In mild cases of carbohydrate intake may be gradually reduced, but in others it needs to be significantly reduced. On this side of the page here, it's got different foods showing how much their content of carbohydrates. And I use something similar when I'm working with clients to show, well, these are the foods people need to eat more of: non-starchy vegetables, the fruit that's not too high in blood sugar, in glucose, meats, etc. And it's got a little graph down, a little chart down here showing the breakdown of carbohydrates, fats, and proteins. Detail's not important, but what it is important, I think, is that people realize this is not a new concept. Before insulin was developed, discovered, and then used as a treatment for diabetes, the standard treatment for diabetes was to reduce the amount of glucose going into the system, reduce the amount of carbohydrates in the diet. So I've kind of misled you when I'm saying it's latest trends, because it's clearly not. It's been around for a long, long time. We've just lost our way over the last 30 or 40 or 50, well, 70 or 80 years since insulin was developed discovered in 1922. I just wanted to point this out. If anybody's watching this and then goes, oh, well, I'll just go on to a, reduce my carbohydrates. If you are taking medications for your diabetes, then you need to be aware of some of those things. Do you need to stop some of those So I would never recommend somebody who is taking diabetes medications to just change their diet radically without knowing what the implications of the drugs are. So again, don't need to know the details, but there are some drugs, so insulin, for example, both long-term and short-term, the sulfonylureas, which cause insulin secretion to go up, meglitinides increase the insulin to go up. So any of the drugs which cause insulin to be secreted from the pancreas, if you then reduce the amount of carbohydrates significantly that you're eating, you need to be careful, because you don't want to have high insulin levels from drugs and low glucose going in. You can cause some problems with hypoglycemia. So that's just a word of warning. Don't go off and change it without some professional help if you are taking diabetes medications that cause insulin secretion to go up. It's not all about diet. Now, obviously diet is the main factor, but exercise and other lifestyle factors can cause blood glucose levels to go up, can cause insulin levels to go up. And this is where I think I mentioned back there with Verta Health and with Diversa Health and the work that I do, it's about helping the person identify what are all the things that contribute to blood glucose and insulin levels not being right. Again, details not hugely important, but you can see from both of these little screenshots that I've taken, things that can affect blood sugars. So clearly, carbohydrate intake is the biggest one. Fat and protein intake do cause, well, protein can cause insulin level to go up a little bit depending on what else you're eating with it. The meal timing and how often people are eating. Alcohol can be an issue that can cause blood glucose levels to be a factor. And I've had lots of people who have done well changing their diet, and we're still working on the alcohol bit, but that can be a significant factor for some people. If people aren't sleeping well, clearly if people aren't getting any exercise, that contributes to the higher blood glucose levels. And environmental factors. So there's a number of things. Stress. I see that a lot. People who are stressed, we go get that stress response. Cortisol gets released into the body. Cortisol tells the pancreas to release insulin because we want to save energy. And, same thing, we've got high insulin levels and also causes blood glucose levels to go up. So it's not just about food, although that's clearly the main thing. Who can get type 2 diabetes? So I'm presuming people on here today have got a self-interest or interest for somebody else. But just to give you a sense of who can get that, and I can see I've missed a question mark off that bottom one. But men tend to be at higher risk than women. If someone in your family has had diabetes, if there's a genetic predisposition, if your mother got gestational diabetes or was overweight while she was pregnant, that can increase your risk for diabetes. Some ethnic groups are at higher risk for diabetes. So, for example, people from Asian, Hispanic, and African Americans tend to be at higher risk for diabetes without putting on as much weight. Clearly, if you're carrying extra weight, that puts you at higher risk, and especially if that weight's found the middle. So men who are, not necessarily carrying a lot of weight, but got a lot of weight, carry all their weight just on their stomach, that can be a risk factor. People with high blood pressure, now again, which is the chicken and which is the egg? Does the high insulin levels cause the problem, or the high blood glucose levels or the high insulin levels cause the blood pressure? Potentially. If you don't exercise much, you're at higher risk. If you smoke, what else can show up? People with low testosterone levels, men with low testosterone can be a factor for increasing your risk. In reality, anyone can get type 2 diabetes. I've said to a number of people, I could turn myself into a diabetic in 3 months if I really tried hard enough by eating all the things that I don't tend to eat, and stop exercising, and start drinking a lot more soft drink, etc. I have no doubt I could be diabetic very, very quickly. And there's lots of people out there who could be. What are some of the early warning signs or what are some of the ways we can test for this? So here's kind of the time path. Again, you can see the insulin and the blood glucose levels on this graph. The blood glucose levels in the blue and the insulin in the green. The orange is body fat levels and the dark green is insulin resistance. So what causes that? Often it's because people can't burn fat. Now, people aren't burning fat for energy. Fat's our best source of energy for providing the energy we need for our brain to work and our body and our muscles and everything else to work. But if our insulin levels are high and we can't burn fat, then we start to get insulin resistant because we start putting on weight. So anyone who's overweight probably isn't burning fat very effectively, because that's why it keeps storing away and not getting burnt. So poor fat use results in obesity, results in that pre-diabetes, and these numbers are from the US or UK, so I'm not quite sure, but you can see the progression. And what does it start with? It starts with poor ability to burn fat, and insulin is the key driver that stops us from burning fat. What are some of the blood tests for diabetes? What would we measure? Well, typically we measure blood glucose levels. We measure HbA1c. They're the two things that are standard kind of tests for diabetes. But if you've listened to all the stuff I've said, what should we be measuring? I think we should be measuring insulin as well. We actually want to know well before blood glucose levels get high, is somebody insulin levels high. And as I said, I've seen a number of clients come in here whose blood glucose levels are borderline or even not too bad, but their insulin is very high. So fasting insulin is a useful blood test. And knowing both fasting glucose and fasting insulin gives us a measure called HOMA-IR, so homeostatic model of insulin resistance. What other blood tests are useful? Vitamin D can impact people with low vitamin D, can impact their pancreatic function, so not producing as much in insulin as needed. What else can we do? I talked about being able to not being able to oxidize fat. I'm lucky in the clinic here. I use a little device where I can actually measure people's fat oxidation to see how well they're burning fat. And really all of the work that I do is trying to help people get better at using fat for energy instead of glucose, because that's what the system's designed to do. So bit of a plug, I guess, for what I do, but testing for that fat oxidation is a key thing. If people want to find out more, obviously they can come and see me. I get a lot of pleasure out of helping people improve their health from a preventative health space, and helping to get people off their medications. So listen, that's kind of the end of the presentation. I am going to open up to questions. So I'm just going to have a look at how if you're muted and you want to unmute, let me just open the chat. Okay, so if you've got a question, you want to stick it in the chat box, that's fine. Or if you want to unmute yourself, probably the chat box is the easiest way for me to see. So I've had a question here. What's the relationship between metabolic syndrome and type 2 diabetes? What is an acceptable level of HbA1c? Let me answer that first. I think I did say earlier on, less than 6.5% is considered normal. Around 5% would be better. What's the relationship between metabolic syndrome and diabetes? Metabolic syndrome, interestingly, used to be called insulin resistance syndrome. So really, metabolic syndrome is an indicator of diabetes. Metabolic syndrome is probably a measure of somebody's diabetes risk. So someone's diagnosed with metabolic syndrome if they've got high triglycerides, low HDLs, a high waist to height ratio, their blood glucose levels are high, and they've got high blood pressure. So if you've got two or more of those, you're considered to have metabolic syndrome. what's the underlying relationship with all of those? I think it's high insulin levels. So I think they're both I think diabetes and metabolic syndrome are both outcomes of a metabolic system that's not working effectively, and insulin levels are getting too high. Okay, another question. If someone has high fasting blood sugar levels but normal HbA1c, would you recommend having a fasting insulin level done? I think a fasting insulin level is really helpful. So it would be done at the same time as your fasting blood glucose level, because we want to look at the relationship between your glucose and your insulin. So yes, the short answer to that is yes. If someone's got high fasting blood sugar levels, then I would get an insulin test done. HbA1c, as I said before, one of the researchers I follow doesn't think it's a great measure because some people's hemoglobin sticks around in their body longer than others, and so they may naturally have a higher or lower HbA1c when their blood glucose control is not actually as good as that indicates. So I hope that's answered that question for you. Any other questions, stick them into the chat box and I will do my best to answer them. I'll give it a minute in case somebody's typing. Okay, can't see any other questions. Listen, hopefully I have answered any questions or helped to clear up any confusion. And this is a confusing area. This is a changing space, as is the world of nutrition, and clearly the two are quite linked. But it's a changing space, and if people sometimes often come to me and say, oh, it's so confusing, there's so much misinformation or conflicting information out there, and I think that's very true. So if you're confused or conflicted, then if I can help, please, that would be great. Somebody else has popped in another question, so I will answer that. Intermittent fasting, reduced blood sugar level. Yes, listen, I realized sort of 3/4 of the way through, I didn't talk about fasting, but I think intermittent fasting is a great way to help manage blood glucose levels. My qualifier on that is, if you're eating a standard Australian diet, lots of grains and cereals, intermittent fasting is really hard to do because you get very hungry. So I always, with clients, I recommend we go, if it's appropriate for them to reduce the amount of carbohydrates in their diet, then yes, I will work with that first and then introduce the fasting, because if you go from a standard Australian American diet with high carbohydrate content to fasting, it's hard to do because we just get too hungry. Somebody's asked how we can access the recording. This will be put on our HFRC's YouTube channel after we finished. Sorry, Helen. Can you just come back and go what you were asking there, Helen? What the MODI?
Yeah, mature onset diabetes in the young. How does that come into it?
Say that again, Helen, sorry?
The MODI form of diabetes, the mature onset of diabetes in the young, does the diet type thing work with that as well, or is that more?
Listen, if people have, I think you're referring, were they also called LADA, late onset diabetes?
Well, it's just that there's a Joey Kay who's working on the MODI, and he says it's a familial thing. It comes down through the mother generally, and my grandson has it, but he's not having to be treated with anything, but he's, apparently the blood sugars go up high and stay up high longer than others, but then they do come down. So
Okay.
I'm just wondering how that fits into whether the dieting and things like that would affect that form.
As a general answer, Helen, I mean, anything that's going to keep your blood sugar levels lower
Yes.
is going to be better.
Yes.
So don't put foods in that are going to cause it to go up high.
Yep.
Yeah.
No, that I had a feeling
sense?
that was going to be it, but I just sort of thought, well,
Yeah.
I'll just ask. Yep.
Yes.
Okay. Thank you.
Okay. Thanks, Helen. High cholesterol. Let me just read this. Sorry. Someone's asking about high cholesterol, but blood sugar levels that are pretty normal. Oh gosh, cholesterol is such an interesting topic at the moment. There is a fair bit of debate going on in the medical and research world about how significant high cholesterol by itself is. So on its own, my personal opinion, I don't think that the high total cholesterol, in fact, the research shows high total cholesterol has never been associated on its own with increased risk. In combination with, and you need to look at the breakdown of the cholesterol and also the blood sugar levels and the insulin levels. So all of that combined, it's not a one size fits all. I'm not as concerned anymore about high cholesterol with people if the other things are all okay. So I don't know if I've answered that question for whoever asked that, but probably the best I can do without getting into a whole lot of detail. I'm happy to talk to people individually if they want to get in touch with me.